the concept of canaloplasty really appeals in restoring physiology.
Because you're actually using the anatomy into your favor rather than creating a new anatomy, if you want.
I think the beautiful thing about canaloplasty is it's maximizing the outflow pathway.
There is no additional damage.
Canaloplasty for me gives you the advantages of MIGS without having an implant.
More physiological and normal not to have an implant.
Patient choice and selection, so getting the right patient. So, for example, anatomy, open angle, relatively early disease.
The patients that I want to be performing either a combined cataract or canaloplasty on are patients who, they may or may not be on glaucoma eye drop. Maybe they just had SLT. Maybe they had a few SLTs over the last decade, and now we're kind of getting to the end of the repeatability of that SLT procedure. So we have to be thinking differently.
The most important factor to me is patient selection and expectation and goal setting. What are you trying to achieve? What are your goals? And what kind of patient is it? If you have an advanced patient with a small central eye on the left and the pressure is 45, you know what, this may not be the best procedure for you, right? Number two is that intraoperatively, making sure that you have a good view. So surgically, get yourself comfortable with the amount of viscoelastic in the eye, how much head and scope to tilt, and how much pressure on the gonio prism.
I think that in any mixed IGA, the visualization, the positioning of the patient on the microscope is crucial to have a good view of the angle.
The visualization is always most important during the surgery, so get your gonioscopy correct so you get a really good view. My biggest tip is always increase your microscope light, because you lose light with gonioscopy.
It's the coordination with the assistant, because it's important that when you are injecting the viscoelastic, when you are dilating the canal, the assistant has to be coordinated with the surgeon to deliver the right amount of viscoelastic.
You don't need a phenomenal surgeon to do it properly, but getting training, visiting people who do it regularly to get the tips and tricks, going to conferences, coming to booth talks, watching an interview, really getting the technique right is so crucial.
We use this illuminated catheter, which gives me the best control to see where I've opened. Is it within the canal? Should I change something? The second thing is I can titrate the amount of viscoelastic and add much more than in any other canal-based procedure.
Don't be afraid to push more viscoelastic. I say 3 to 4 at least clicks or so of viscoelastic per clock hour. That's about 10 or so 11 microliters of viscoelastic per every clock hour. And first I was a little bit more fearful of that, but now I feel comfortable doing that. I think that allows us to really flush the entire system out, create those herniations in the TM, and also help the episcope venous system and help the collector channels open up as well.